how much are patients doing what their doctor tells them versus researching and saying, I don't like the sound of cardiac toxicity or neurotoxicity, I'd prefer one or the other?
So I think that having that level of knowledge is a little bit unusual, but there are certainly patients out there who ask those questions. But there are, one of the things that we've seen in our patient navigation center and some of the things that we've seen online from patients in our Facebook groups, et cetera, is that patients are interested in alternative medicine and other ways of sort of augmenting their therapies, and that's a little.
Do you encourage that, or do you?
Of course not. Of course not.
Right.
Certainly, our response to that is, if you are interested in alternative therapies, please discuss with your doctor before you try anything. And you know, I think it's, in general, it's a pretty bad idea for people to think about going off their therapy and you know, using an alternative therapy. So that's certainly something that patients need to discuss with their doctors up front, and that's what we encourage.
What about cost here? Kyprolis, bortezomib is going generic in some countries already, Canada, I think. Although I guess there's still, it's only intravenous delivery, so there's still sub-Q branded product. Do you think the cost will factor in when comparing? Do you think there's big enough difference in favor of Kyprolis to justify the increased cost for the payer?
So I think you can answer that two ways. If you're a patient, if I was a patient and I've never been sitting in that chair, I know today that I would want to get carfilzomib as my preferred treatment. Now, if you live in a country with resources that have to be allocated in a way that it's different from ours, I would say it's a perfectly legitimate thing to be using. Not only that, but you could use Cyborg as an introduction regimen, which is the bortezomib combined with cyclophosphamide. I think in the United States, truth be told, if we look at efficacy and toxicity, and I think in a growing number of myeloma experts, the opinion is that KRD should be the standard induction therapy.
And to some extent, Forte trial is further validating that notion. There is no RVD as a comparator in this study, but both arms, to some extent, are almost mirroring what we have previously observed. So to the patient discussion, which I have as making my points, what to choose between one or the other regimen, eventually what makes the biggest argument is when they look at Kaplan-Meier survival curves, and I will tell them that with this type of treatment, at 4 years, your probability of relapse will be, say, 20–30% when we have KRD transplant. That's our data, what we have, versus more than 50% when you go with RVD, with or without transplants. So this is very much appealing argument, short of ultimate evidence from randomized trial.
What do you tell your patients about toxicity of carfilzomib, particularly as it relates to the heart?
Everything, everything what I know. It's a hard discussion which I have. I cover everything what I know. In short, there is no question that when bortezomib has Achilles heel, as I call it, in form of neuropathy, which is more than most patients want to take, and there is no question about it, that the Achilles heel for carfilzomib is cardiovascular cardiopulmonary toxicity. And I tell them that more than 30% of patients will have some subjective impact of this toxicity on how they feel in the form of fatigue.
What is your estimate of how common it is in a newly diagnosed patient?
In about 30–40% of patients, there is some level of what we call dyspnea, suppression of. Yeah, that's coming from the studies. You have combined effects. They are very subtle. We can pick it up by talking to the patients. They are clinically meaningful.
Serious cardiac toxicity.
Serious is then less than 4%, and with good management will be less than 4%. So that's what the discussion is. If toxicities emerge, we've learned how to do it to avoid to be in this 4%, and we also can manage that 30% that we have efficacy and not necessarily toxicity, which is unacceptable.
And we do hear from patients a lot that neuropathy is a very serious problem for patients. And I've actually heard patients complain that their doctors never really told them how serious neuropathy could be when they were talking about which initial therapy they could go on. Yeah, so it's a big concern for patients.
And it's less a problem now, but in the early days, not having the experience, people would keep treating beyond the first symptoms. It could get pretty bad.